emergency pediatrics, and in that time you will have to give morphine orally, or morphine subcutaneously, or morphine intranasally, or morphine IV. One thing is that morphine, most important of morphine is it is available in every route. You can give oral, you can give subcutaneous, you can give intranasal. Now how they give these routes, this is very important for our exam. Okay, so this morphine dose and morphine transformation, like from you can see in my group, I already posted my handwriting. That's very bad handwriting. I posted already. That is how to transfer between morphine to diamorphine to oxycodone to oral morphine to subcutaneous morphine. So I already gave you those schedule how we transfer. Okay, so this morphine is very important. Now this you have to remember. Now there are other varieties of pain medication like codeine, fentanyl. So every mechanism of action, dose is not so important, but mechanism of action and how they act, are we going to use patch, or are we going to use subcutaneously, or are we going to use orally? So this formulation, this indication, this mechanism of action, very very important. And also side effect, and how we going to prevent the side effect. Like morphine has many myths. You know what myth means? False belief. So morphine has many myths, like morphine, oh my god doctor, you are giving morphine. Like I'm saying my personal experience. My daughter, when she was 10 years old, she has appendicectomy. Okay, and she got very severe type of, nearly burst appendix, and that time she got surgery, and 24 hours she was on IV morphine. Okay, and I was a pediatrician, but I was very much anxious that she's getting IV morphine. Okay, I was very much anxious. So IV morphine is safe. Morphine is safe for pediatric patient. Even below 1 month, we can use morphine. If you see the Red Book Pediatric Guideline, you can see that below 1 month even we are using. If the patient is in surgery, you have to give IV, because the patient will feel musculoskeletal, muscle pain. Because when you are doing surgery, definitely he will feel pain after the anesthesia gone. So you can use IV morphine, you can use subcutaneous. Now, when I will use IV, when I will use subcutaneous, this you have to know. Okay, for this you have to read from different books, like RCPCH has many books, like Royal College releases different leaflets about palliative care. I found many leaflets when I searched, and there is a patient info website I shared already in my groups. That website has many methods how we will give palliation. So you have to know. And also our book, like Science of Pediatrics, this is a very nice book. Okay, I first time when I was like you, I was like part 1 student. I did not actually I did not give so importance. But after that, when I am starting as a teacher, and I am reading this book, then I said, oh my god, this question was from this book. So this question was from, so Science of Pediatrics, though it is a very vast book, but it has statistics chapter, it has palliative chapter, it has ethical chapter, it has pharmacology chapter, it is section wise. Okay, systemic book, very good book. So you can go through this Science of Pediatrics book. It has a palliative care chapter, and in that book you will see that there are different side effects of morphine, and those side effects, how we manage those side effects, like constipation, like respiratory depression, like many people think that morphine will make dependency. Actually, the pain dose, this is the not a dependence dose. So it does not make any dependency. Even if it makes dependency, it goes away. After we stop the drug, it goes away. So this morphine is a very safe drug. But one thing you have to remember, what are the other varieties of morphine, like codeine. Codeine is also one kind of morphine, but we don't use codeine below 12 years, because when codeine goes in our body, it metabolizes and into morphine, and how much it metabolized, that actually unpredictable. Okay, because it depends according to the liver enzyme, according to the enzymatic, there are certain enzyme involvement. So that's why we don't use morphine codeine below 12 years, because it is unpredictable. Now there are other varieties of opioid like hydrocodone, diamorphine. So what are those? Those are actually commercial preparations, like different varieties of morphine, okay? And the strength is different. So when you convert from oral to subcutaneous or IV, you have to know how I will convert, okay? Now, sometimes the patient develops side effect, he is using morphine, but he can develop side effect. Severe constipation, severe swallowing problem. One thing you know that how morphine act via mu kappa delta receptor in our brain. It is centrally acting. So these receptors have some action on the gut, action on the respiration, action on the skin, action on the eye. Morphine causes meiosis. So these receptors have some side effect. So like severe constipation, severe swallowing problem, or any patient who has suppose renal disease, then how you will treat that patient? You will treat, of course, by other varieties of painkiller, because morphine is not so good. So in that cases we can use fentanyl. Fentanyl is also available in patch, in subcutaneous, in IV, okay? And so you have to know everything about pain management. Now I am only talking about pain management, but there is another symptom like secretion, like respiratory compression, like bowel and bladder incontinence, okay, like constipation. These are also terminal symptoms. So any patient, suppose who is a cerebral palsy patient and he develops severe secretion, okay, you have to give medication. And now which medication? Suppose anti-cancer drug, we know the side effect of anti-cancer drug is vomiting, nausea, severe nausea. So in those patients you have to give anti-emetic. Now what anti-emetic you will give? That is a question, okay, that came many times in part 1, also part 2. So in vomiting we have domperidone, we have ondansetron, we have metoclopramide, okay. So these drugs when we use, this is you have to know, this is basic. And now there are certain other drugs like adjuvants. What do you mean by adjuvants? Adjuvants, like this is a helper, this is a helping drug. It helps along with analgesia. Like they are not true analgesics, but they help as analgesics, like phenobarbital. We know that this is not an analgesic drug, but it helps. And bisphosphonate, we know that bisphosphonate is not an analgesic, but it helps in bony metastasis, okay. And other drugs like radiation is not an analgesic, but in terminal cancer, bony cancer, or severe pain in a muscle or joint, we can give radiation therapy as a adjuvant of analgesic, okay. So this thing you have to remember, that there are certain medication that will help to relieve the pain. They are not directly painkiller, but they will help. These drugs is called adjuvant, okay. Like for dyspnea we use oxygen, right? But more than oxygen, another drug is opioid. We can use low dose. For dyspnea we can use low dose morphine, low dose opioid, okay. Now there are certain emergency procedures in palliative care. Suppose a patient is terminal cancer, but he developed pancytopenia, febrile neutropenia, he developed cord compression, he developed superior vena cava syndrome, he developed severe bleeding due to pancytopenia or thrombocytopenia. Now this is an pediatric emergency. So though the patient is in palliative care, but he needs some emergency care. So some emergency physician is involved in palliative care also. Now you will find some ethical question in palliative care, like a child who is not GLIC competent, 10 years or 8 years, 9 years, there is a 50-50 chance that he will cure or he will not cure. Parents does not want continue treatment, but the child wants, because some he understand that I need treatment, and he likes doctors, he likes hospital nurses, so he has no problem with therapy. But parents does not want, because parents are already counseled that there is a 50-50 chance of this patient. So what we will do in those cases? Of course, we will have a meeting, a board meeting, because we need to hospital legal action or legal committee, because 50-50 is not a bad chance. So we can give him, because he is not a failed child, like failed chemotherapy, repeatedly given, not that. There is a 50-50 chance. So in that cases, as the child is a minor, as the child is a 10 years old, 9 years old, he is not GILIC competent. In those cases, we have to go for legal action, because mother and father, they are legal guardian, but they do not want. So this is called legal ethical question in palliative care. Okay, so remember, ethical question can come in any chapter, in respiratory chapter, in gastroenterology, in cardiology. Any chapter can come as an ethical issue. And we have a live Facebook live about ethics. I hope you most of you have seen this video. So you will see that video in my live section in this group. Okay, so what was our today's topic? Okay, palliative care. And what we came to know, that palliative care is an umbrella. Among this umbrella, there was different varieties of treatment facilities, and actually palliative care improve the quality. It does not improve, it may or may not improve the quantity of life. So among this palliative care, there is hospice care, there is chaplain. Now, who are hospice? Who are chaplain? For the new people who does not know, telling, many people, I hope you know who are hospice care. Hospice care means they are terminal care providers, hospital team. They arrange for post-mortem, they arrange for dead body burial, dead body transfer, dead body cooling, or they arrange for last wish, terminal wish, where the child will die, how he want to die. He want to die in hospital, he want to die in home, what the family needs psychological support. So these all issues are dealt with hospice care. Now, who are the chaplain? Suppose some parents are very much religious, Muslim or Christian or Hindu, anything, and they want a religious leader. Suppose some parents does not want bovine porcine, does not want bovine porcine or pig porcine or animal porcine. Now this chaplain, they are the religious leader. Actually, they can counsel the parents that this medication is important for your child, and for treatment purpose, we can use pig, we can use bovine, we can use animal products. And like some parents may be very much crying, they need some psychological support, so you will refer them to the hospital hospice care. And some parents actually need to pray in hospital, they need dua or something, so they will be referred to the religious leader, that is chaplain. Okay, so they are different people in the palliative care. Like in the palliative care, there is a telephone service 24-hour. Suppose a child died and parents are crying, mother is crying horribly, who have this experience, they know, and these parents need support. So in that cases, they will call the telephone service, they are 24-hour available, and they will come down, they will give them support, they will tell them that okay, come tomorrow and visit our psychological expert. Okay, this is called hospital bereavement team. Bereavement means in shock. In Bangla we can say shock. Bereavement is a grief, sadness. In those cases, you will refer the patient to those team. Okay, so this is hospital bereavement team. So we came to know that this palliative care actually not only to give comfort of the patient, it can give comfort to the child, it can give comfort to the all the family members, relative, even grandparents, even sibling, they support. Okay, and they not the support, it not only finish after the child died. No, suppose the child is buried. Okay, we think it is finished. No, palliative care will be continued unless the parents are calm, unless the parents actually they take it as a life, as a nature of life, okay, until unless they want. So until then, palliative care will be continued, like they will give support to the parents. Now, regarding this palliative care, there will be one or two question from the pain management or management of the symptom, and one or two question from the palliative other side, other branch. So actually 3 to 4 question in palliative care. So this is a very very important chapter. And in our class, in our part 1 teaching sessions, we have a divided class in ethics and one class in palliative. And this palliative section, we usually discuss many example, like I am giving today, like many example. A child is dying, what will do? A child is having secretion, and in this patient, what will you do? So we discuss many things in our session. Our class is very much extensive. I usually take 3 hours, 4 hours class. In between there is break, and we discuss many palliative care, okay. And from books, it will help you from website or from RCPCH website, they will help you. But reading books always, it is not so much comfortable, okay. If you discuss with us, if there is someone to discuss with you, that is very helpful, I believe, okay. And I this 2 months actually I am a little bit busy with my exams and my preparation, and also I'm moving from Bangladesh to another country. That's why I did not take any batch for next 2 months. But in February, my next batch is starting from 1st February, inshallah. And all of you are welcome in my batch, okay. You can talk to me on my WhatsApp, you can message me personally on Facebook, WhatsApp, if you have any query, any question regarding part 1 preparation, regarding anything. Like I am not even clinical also. I'm not like for teaching only, no. If you need any advice, I am ready, I'm available. And if you think that you are giving DCH exam, suppose you are giving FCPS exam, suppose any exam, actually this preparation will help. I hope MRCPCH is a very very well recognized exam. This exam has every chapter, every specialty. I'm a consultant. I passed FCPS, but even though I did not read many chapters when I was doing my fellowship, because these ethical chapters, these palliative chapters, they are not so popular in our country, but they are popular in UK. So this MRCPCH exam, I find it is a very very nice exam, okay. Even if you can't complete it, even if you can't finish part 2, even if you can't finish part 3, but it will help you definitely in your next exam, next life. Because many of my treatment modalities I changed after I passed exam. I changed, and I came to know this is a so nice exam, this is so nice knowledge. Today I was seeing YouTube video of diamorphine, how to use intranasal diamorphine, okay. I never gave, this is my bad luck, I never gave, but I will give inshallah one day when I will work as a ER. So how you give intranasal diamorphine, you can see in the YouTube video, but when you actually give in your hand, that will be your real time pleasure. So I hope all of you will be dedicated to your study. Remember that success has no shortcut. I don't believe success in shortcut, I don't believe. Because I finished almost 120 students in last 1.5 year. I finished 120 students in MRCPCH part 1, and these 120 students, I tell one thing, that is success has no shortcut. If you want to be succeed in life, you have to go a very long way, a very rough way, okay. Study, this is the only thing you can be self-satisfied. Even if you pass, many people I saw, they pass the degree, but they don't know the management of emergency management. They are like shaky, you know. They are when they saw a congenital heart disease patient, they are like shaking. What I will do, TGA patient. I saw many fellow, and I saw many consultant level even, they are shaking. This shakiness, it will go if you have knowledge. You know, the mind does not know, the eyes cannot see. Okay, so you have to read. The people who says you that don't need so much, only past test is enough for MRCPCH, I don't believe them, because I worked very hard when I did part 1. I worked very hard, and I did very hard work in part 2, and I am doing hard work for clinical also. So success has no shortcut, believe it. And read as much as possible, but there is a smart way. What is the smart way? Smart way is that you have to be properly guided by some seniors, by some friend. Who is your friend? Okay, like I was guided by very two close friends of mine, Ilhama and Rihanna. Okay, they were my guide, they were my friend, and they are still now with me, and I'm thankful for them. Okay, they are guiding me that Tamanna, read like this, read like that. Okay, and I was reading with them. So if you get a very good friend, if you get a very good colleague, if you get a very good teacher, okay, your pass is confirmed. Okay, but you have to be prepared for your hard work. Like this time, my students, alhamdulillah, I was not expected so much passing rate, and they all got 75 to 85. They all, nobody got below 75. That means I was guiding them so hardly that you have to read this full chapter. You have to read this full chapter. Then what was there? They had a push that no, I have to read this because ma'am said it have to. So remember that success has no shortcut. You have to be very hardworking. Okay, read, do work. When you are doing your round, finish your OPD, then start your book. Like I did. I finished my round, I finished my OPD, then I started reading. Okay, then after 30 minutes, I was called by ER or something, and I was rushing. So like this, like I was sleeping 30 minutes or 1 hour, then again I wake up and I started reading. So remember all time that what I am telling you, this is not only for your MRCP exam, this is for your life, for your whole life. And as a doctor, I know that I have to read all over my life. Because if you see Nelson, I started Nelson reading 17th edition when I was a trainee. This is 10 years back. I'm talking about 10 years back. And now Nelson is 21 edition. So from 17, 18, 19, 20, 21. 5 edition I have Nelson. And this 5 edition, I saw many treatment changed. Many treatment that was the first line, now it is obsolete. Many treatment that was first line, now it came to second line. Okay, so remember that your study is not finished. This exam if you pass, next exam if you pass, you will be consultant. You have trainee under you. They want to know, sir, what is the most recent treatment. Now if you tell like 10 years back treatment, it will be false. It will be will be false. So you have to know the recent guideline. So I am telling you that studying is a matter of end of life, until end of your last breath. So don't neglect your study. Don't be bored of your study. Okay, this is my advice, that don't be bored. Try to make study in a very comfortable way, in a very soothing way. Okay, when you are very much tired, look at YouTube, look at Google, look at like some PDF when you are very much tired. Okay, and make some good friends, make some colleague who will help you to pass through this hard working path. Okay, and for me, as long as I am here, I can teach you, I can guide you, and also I am here to help you. And my teaching sessions will start from February 1st. And if you like to join me, welcome. If you don't like to join me, then also you are welcome. Welcome for sharing with me any knowledge, anything, like your any experience you like to share, you are more than welcome. And inshallah, pray for us, pray for all, and pray for this. This is pandemic is going on. All the Muslims, I pray that please pray while you are doing namaz, and other religious believers, you also pray in your language. Okay, pray for all of us so that we can be a good doctor, we can save and we can cure many patients. And also keep studying, okay? This is my last request, keep studying. Okay, thank you for everyone. Today we did many chit chat. If you find this live was helpful for you, please make a comment so that I can be inspired and I can come again for you. And thank you everyone for joining and listening to me. You gave me time. I'm very much thankful. Okay, Allah Hafiz. Thank you. Bye bye.